Dr. Oberholzer from the University of States will be giving a talk to us and interesting topic on whether we should be treating HPV positive versus HPV negative penile cancers differently. Thanks a lot, John.
Thank you for the opportunity to present on this breakfast talk. So like you said, I'll be presenting on whether we should treat HPV-associated penile cancer differently from HPV-independent penile cancer. I'm one of the registrars at the Department of Urology at the University of the Free State. So the reason for this talk is to look at alternative treatments for penile cancer in the near future, as well as how we can apply this in the South African healthcare setting. I'll briefly talk about the history of HPV and penile cancer, the current vaccination policies regarding HPV, promising treatment modalities for HPV-associated penile cancer, the recent trials that are ongoing, and then the relevance in the South African healthcare setting. So all of us, unfortunately, sees the left bottom picture way too often. Patients presenting late already with a or2 amputation with limited treatment options left for this patient. And I think we would rather see the picture left at the top. Penile cancer is a devastating disease with high morbidity and mortality when patients present late, but early disease still has good oncological and cosmetic outcomes, in contrast to potential mutilating advanced disease. It's a relatively rare disease in developed countries with an incidence of 1 in 100,000 men. According to the National Cancer Registry in 2019, the incidence is estimated to be 1.36 per 100,000. And according to GloboCan, this incidence in Africa is expected to increase by 110%, but this, however, excludes South Africa from the list of statistics. HPV results in approximately half of penile cancer, and this might be possibly high in South Africa with the large HIV burden. The virus was first discovered in 1956, and in 1984, Harold Zurhausen attributed HPV 16 and 18 to the development of cervical cancer. It's only in 1995 that HPV was first recognized as an oncogen. It's detectable in 51% of all penile cancers globally, but this prevalence is higher in South Africa. So it's a small double-stranded DNA virus, and the two primary oncogenes of high-risk HPV subtypes are E6 and E7, which inhibits p53 and retinoblastoma protein tumor suppressor genes, respectively. About 5% of all cancers worldwide are attributable mainly to those known as high risk, including HPV subtypes 16 and 18, and there are numerous other high-risk subtypes described over the years. Infection with HPV is common after sexual initiation, but most infections clear within 12 to 24 months. It's only a small fraction of infections that persist or progress to a preneoplastic lesion resulting in cancer. Regarding cervical cancer, the HPV oncogenesis is well known. It's poorly understood in penile cancer. The proposed two mechanisms how HPV affects the epithelium is one, the viral infection can result in low-grade lesions such as condylomas, or it can lead to precancerous lesions, which occurs when the viral genome is included in the host's DNA, and there's consequent overexpression of oncogenes and uncontrolled cell proliferation. This diagram just illustrates the difference between the HPV-dependent and independent pathways. As you can see there, the E6 and E7 activation leading to the degradation of p53 and inactivation of the PRB tumor suppressive genes, respectively. And importantly, when it comes to the histological identification of the virus, there's overexpression of p16 inc, which is now the gold standard in identifying HPV. The virus also creates a or penile cancer in general, there's a tumor enhancing and tumor suppressing environments that are created by the various factors and prostaglandins, and this is where targeted therapy comes into play. So looking at the risk factors, commonly HPV infection, the high-risk subtype 16 and 18 mostly, phimosis, chronic inflammation, lichen sclerosis, and tobacco, and this includes all tobacco products. The vast majority of penile cancer are squamous cell carcinomas, with a majority originating in the mucosal lining of the glans, coronal sulcus, or foreskin. In 2016, the WHO classified tumors based on the relationship to HPV, and in 2022, they subclassified it as HPV-associated and HPV-independent. So historically, pathology regarding HPV looked at cholestatic-like changes, necrosis, moderate to marked pleomorphisms, and invasive front nests when identifying HPV. But now block type P16 immunohistochemistry is the mainstay to differentiate HPV associated from HPV independent penile CA. This is from the WHO's new 2022 histological subclassification, with HPV associated including bacilloid, warty, clear cell and lymphoepithelioma like squamous cell carcinoma. In contrast to HPV independent, your squamous cell carcinoma usual type, verrucous papillary and sarcomatoid squamous cell carcinoma. When looking at some of the literature, there's a significantly better 5-year survival reported for HPV-associated versus HPV-independent penile carcinoma. There's no difference in lymph node metastases and 10-year survival. HPV positivity predicted for an improved loco-regional control in the pathological node-positive disease compared to HPV-negative patients. And from this article, men with HPV DNA or P16 positive penile cancer, it was shown that they have a significantly more favorable disease-specific survival compared with HPV P16 negative patients. But neither HPV nor P16 status were predictive markers for overall survival. So there's a possible clinical value of HPV and P16 testing when planning the most optimal management and follow-up strategy. When looking at prevention of HPV, prevention is paramount with, it's known that circumcision significantly reduces genital HPV prevalence, condom use and to limit the amount of sexual partners, and then vaccination. It's also an important role player in the past 20 years. So the South African EPI currently includes vaccinating girls aged 9 and older, and this campaign was employed since 2014. The effectiveness of the vaccine is, however, low in individuals who are already infected with a corresponding HPV subtype. Previously, there was a concern for low rates of HPV antibody seropositivity, but the quadrivalent vaccines have proven to be highly immunogenic in males aged 16 to 26. Seroconversion starts at 7 months, with antibody titers comparable with female counterparts at 36 months. It's very effective in HPV-negative males, and the recommendation is thus to vaccinate boys at an early age before sexual activity. There's currently 33 countries who have employed HPV vaccination in men, but the WHO has recently called a halt on vaccinating men due to a global shortage that is expected to last till 2024, as the aim is to vaccinate females prior in the fight against cervical cancer. The CDC Advisory Committee recommends the following, with routine male vaccination from ages 11 to 12 with either the quadrivalent or bivalent vaccine, vaccinating males aged between 13 and 21 who have not completed the 3-dose cycle, and then vaccination of patients aged 22 to 26 your high-risk patients, such as those including men who have sex with men and immunocompromised patients. Interestingly enough, the EAU currently recommends against the routine HPV vaccination of the male patients as a method in reducing penile cancer risk. So there's already well-established treatment that exists for penile cancer for primary and metastatic lesions irrespective of HPV infection. However, HPV-targeted therapy remains a promising treatment modality. There's multiple experimental trials currently in head and neck regarding HPV-associated squamous cell carcinoma, as well as cervical carcinoma, and recently targeted therapy is also being trialed in penile carcinoma. So this diagram gives a nice illustration regarding the immune evasion strategies of HPV. As you can see early, there's a release of viral antigens and neoantigens, and the virus causes impaired immune activation, which later on it can cause less activation and migration of the Langerhans cells and dendritic cells, causing the cancer antigen presentation to be diminished as well. Causes defective inhibition of T cell priming, and then also creates an immunosuppressive environment. Later on, when tumor cells are usually recognized, HPV causes less T cell recognition. And with the killing of tumor cells, that's usually the final step in eradicating the virus and tumor from the body. It causes T cell inhibition. And this diagram is important to understand where targeted therapy comes into play later. These are some of the phase 1 and phase 2 experimental trials that are ongoing. Under that middle column with the HPV target, you can see the target on the high-risk subtypes, targeting E6 and E7, as well as there's T-cell receptor, T-cell targets, and then some of the drugs that have been trialed, such as aldesleukin. So these are still ongoing, and but there is, however, promise in some of these experimental trials. So coming back to the previous diagram that we discussed, all the modalities highlighted in red are the potential targeted therapies and where they play a role. Importantly, HPV vaccines is seen as targeted therapy in increasing the cancer antigen presentation and increasing host immune response. And anti-PD-L1 and anti-PD-1 is also a promising modality. So with regards to HPV-associated penile cancer, it's associated with increased tumor-infiltrating lymphocytes, stronger polarization toward T-alpha-1 cells, and it causes an overall more significant cytotoxic immune response compared to HPV-independent penile CA. Vaccination against HPV in the precancerous lesions have shown induction of cytotoxic T-cell responses and clearance of HPV-associated precancerous lesions via immune responses against proteins E6 and E7. Doran et al. Conducted the first in-human phase 1 and 2 trials in refractory penile cancer. Patients received autologous genetically engineered T cells expressing a T cell receptor directed against HPV-16E6, a conditioning regimen, as well as systemic aldesleukin. In this trial, there were no dose-limiting toxicities observed in the phase 1 portion, and 2 patients experienced objective tumor responses. Nagashev et al. Conducted the first in-human clinical trial targeting HPV-16E7 oncogene in patients with metastatic HPV-associated epithelial cancers. This is including head and neck, cervical cancer, as well as penile cancer. There was objective clinical response in 6 of the 12 patients, including 4 of 8 patients with anti-PD-1 refractory disease. And there are also numerous basket trials looking to combine the TCR-based approach against HPV E6 and E7, and is also evaluating a combination with nivolumab. In the context of South Africa, I think targeted therapy is soon possible, but it may not be accessible to all. There's limited resources with patients presenting late and a poor understanding and awareness of penile cancer. Having said all this, most institutions are still capable of making an early, accurate diagnosis with a biopsy and assessing the extent of disease with appropriate further imaging such as CT, MRI, and PET scans. And I think one cannot emphasize enough the treatment of lymph nodes in penile cancer with inguinal lymph node assessment and treatment. That is still one of the most important aspects in the treatment of penile cancer, with a significant impact on prognosis and treatment options. I believe in South Africa we should consider vaccinating against HPV, especially in high-risk individuals such as those infected with HIV. The majority of South African penile CA is associated with HPV, and targeted therapy might play a major role in the near future. The future of treatment of HPV-associated penile cancer looks promising. Having said all this, targeted therapy, the data is still lacking regarding this, and I think for now the treatment should stay the same. However, vaccination is a possible, cost-effective, and simple option. Penile cancer overall, the treatment represents a complex landscape, particularly in developing nations, as there is an unfulfilled need for high-level multidisciplinary therapeutic options. Patients have good outcomes with appropriate surgical resection of the primary lesion and proactive treatment of inguinal lymph nodes as well as pelvic lymph nodes when indicated. Currently, the treatment of HPV-associated and independent penile cancer in the South African setting should for now be managed the same until better data is available. Thank you. Any questions?
Thank you so much, Johan, on the presentation. Yeah, it does seem like, because I think we're moving towards targeted therapy in most of our cancers. And I think you brought it quite clearly in the talk that, it does seem like targeted therapy would work better in patients who've got HPV-associated penile cancer, which is quite an interesting concept, because you did mention that there's better local regional control in patients with HPV-associated penile cancer, obviously given adjuvant chemo or RT. Because that chemo RT, that local regional response you're talking about, what is that based on? Because for targeted therapy, I do understand that it does make sense, because you said you target E6, E7, but chemotherapy and RT, and how is it that there's better local regional control in patients with HPV-associated penile cancer?
To be honest, when I read about this, I think it was, as you said, it's mostly with radiotherapy and adjuvant chemotherapy. I don't think this was with targeted therapy already. But yeah, I'm not sure.
Yeah, okay, no. Such an interesting concept, because the reason I'm asking the question, because when you were saying it, I had thoughts about when you always talk about, squamous cell carcinoma, whether it's associated with bilharzia or not, because we do know that patients that have bilharzia tend to have a more, sort of theoretically better survival or control, because they fibrose their lymph nodes and they often don't spread quite widely as a non-bilharzial squamous cell carcinoma. So I thought it's a bit of a similar concept, but I think I'm also not quite sure as well. It's something to probably look at, and how we're getting more local regional control, because it's quite clear in the targeted therapy, you highlighted how that would be of benefit. Are there any other questions for Johan from anyone? That's Prof.
Thank you, Sam. I don't know if you can hear me okay.
Yes, we can hear you, Prof.
Thank you, Dr. Ubels, a fantastic talk. I'm just had some network problems. I don't know whether you mentioned Prof. Wenzel's paper on this topic. Did you quote that?
Good morning, Prof. No, I didn't quote it, but yes, I am aware of you looked at the HPV prevalence in Central South Africa in penile carcinoma. I think it was in 2018 when it was published.
Yes, I think it would be worthwhile just reflecting on that 2018 paper because he showed that he had a large cohort of 60 patients, and he showed that those who were HIV positive were younger patients and had a much higher prevalence of HPV. I think it was 55 versus 24%. But interestingly, contrary to what you had said, there was no significant difference in the histological subtype of the between HPV positive. I wonder why that was. Perhaps smaller numbers, maybe, but it was a 65 cohort, so not a tiny group.
Prof, sorry, I don't know if you can hear me. Yeah, they at the time when they did the identification as well, they looked at cholestatic changes with pathology when they did that study as the method in identifying HPV. We are currently busy with a study. We also have, I think it's at the moment we're at 130 patients with penile CA that we're going to relook HPV incidence as well using P16 stains, where the diagnosis is equivocal, and also just try and relook that. But yeah, it is quite interesting that it's consistent with international literature, the same amount or the same prevalence.
Yeah. Thank you, Johan. I'm just trying to understand this talk. Is it part of your MMed? Is this a topic that you're looking at?
Yes, it's part of the MMed, but the main part of the MMed is actually to look at HIV as a risk factor, independent risk factor for penile cancer, as the EAU currently doesn't see it as a risk factor. But with that, we are also relooking HPV. Whether it's just a confounding variable or actually consistent with HIV.
Yes. And what is your hypothesis then? Do you think it's HPV that's causing the association? Or do you think there's an independent HIV?
I think HIV might be independent. I know in cervical cancer, there's actually it's HIV and HPV goes together, but yeah, I think there might be it might be an independent risk factor regardless of HIV.
Good luck for your work. Thank you.
Thank you, Prof.
All right, thanks a lot for that, Prof. Questions and some comments. There's a question from Prof. Mutambiro. If you can see there, he just wants to know if there's any data between the non-valent and the quadrivalent for male HPV infections, and which one is used on trials in treatment of prostate penile cancer.
I'm not sure. I don't know.
Yeah. Okay. All right. Thanks for that. Prof. Mutambiro, if you can share anything that you know about it, but as far as I understand, I think the quadrivalent is basically enough. But I don't know if much as well on this. I don't know if Prof. Lisa's probably off now. I know she likes the vaccines she might have info on this in cervical cancer. I don't know if Prof. Mutambiro, if you've got any comment on this.
Oh yeah, no, Johan, really great talk. And it's just I know the data for females, the non-valent actually has a much higher complete prevention rate than the quadrivalent, and that's why I know it's a lot of it's company information, but the point is it looks like it increases it by about 48% better outcomes. But I don't think the data is there for males yet. Now I didn't know whether Johan might have picked that up, and it would just be interesting to know what they're using for. I don't know what they're using for the treatments, and that would be quite interesting because it might make a difference in what the outcomes might be. But Lisa obviously would know better than me if she's on.
Yeah, thank you. She might be off actually because she's got a meeting this morning. But I think in the absence of any further questions or comments, I'd like to close off the session this morning. It's an excellent session, recurrent UTIs and HPV and penile cancer. So we'll see you guys in the next week.